in short, I'm going to hopefully by the end of this give you, I guess, an insight into exactly how feasible it is to actually start individualizing for ciprofloxacin, because we've now got plenty of molecular data to basically suggest that it's extremely possible. We've now got the targets. But before I start raving on about all that, I do want you to know I do actually receive research funding from SpeeDx. It does directly relate to some of the work that I'm going to talk about here. So just bear that in mind. So look, David Lewis has already given a bit of a snapshot of this. So this is a timeline of gonorrhea resistance. And again, sorry, it's a bit small, but showing when sulfonamides first introduced, first saw resistance 5 years later, same for penicillins, tetracyclines, and a whole bunch of others. But really what's got everyone's knickers in a knot, so to speak, is that we're now starting to see resistance to ceftriaxone. And so WHO's called this a high priority, CDC an urgent threat. Now, if I just focus on ceftriaxone for the moment, so if we go back about 20 years ago, we started to see these strains that have reduced susceptibility to ceftriaxone that had, just reasonably, the MICs were still quite low, so it was still very susceptible, but we were classing them as decreased susceptible to ceftriaxone. Now, these are typically very easy to treat, but for pharyngeal infection, we're starting to see a few problems. And so this just comes down to the fact that these bugs have a little bit of tolerance for the drug, plus getting those lethal doses up in the throat a little bit more difficult. So we saw a few treatment failures. So as a whole, we weren't too worried about all those strains, but then from 2009 to 2013, this is where things changed a little bit. We started to see these strains that had much higher MICs, and these were ones that we, in terms of the laboratory, were classifying as resistant. Now, we actually got lucky in that these were sporadic, and basically, this made us think, well, hold on, these strains have popped up and quickly disappeared, and so it got us all thinking that maybe gonorrhea is not very good at developing ceftriaxone resistance. So we thought, well, this is a bonus, looking pretty nice. And in fact, I think it was someone in the UK recently describing this. Well, this was really just gonorrhea flexing its muscle, showing it can actually do this. But things have changed. So the FC428 strain is now being reported in several countries. And I should point out it's recently been associated with the treatment failure in France with the pharyngeal infection. But we've also had these new strains popped up that David was just talking about, the XDR strains that we're now in Australia calling the A2543 strains. Now, what this is suggestive is that we do actually have some ongoing transmission of these strains. But the other thing I also wanted to point out, which David's already mentioned, is these A2543 they're also high level resistant to azithromycin. Now, from a molecular biologist perspective, and when you're actually looking at these A2543 strains, you could not engineer these things any more beautifully than what they are. I mean, it's almost scary that they've actually come up with this combination of resistance mechanisms. I just don't know how it came about. But the other thing that also strikes me is that A2543 and FC428, they share the exact same PAN-A sequence conferring resistance. That's 1,800 base pairs that are absolutely identical. Now, for all us gonorrhea nerds, we know that the PAN-A, that's a lot of variation. So the fact that these things share such similar sequences is really bizarre, given their genetic backbones, so the rest of their genome is actually quite different. So it's somewhat suggestive that the gonococcus has now actually formed a somewhat stable form of ceftriaxone resistance. So definitely something to watch out for. Now, the other benefit of that, though, is that it does give us something to target with our molecular tools. I'm going to be talking about that more tomorrow, but tonight I'm going to try and just focus on the individualizing therapy. So, if it moves. So what are we doing about all these issues? Well, I think just about every jurisdiction has now actually released some kind of action plan. And these are the types of things listed here that you actually think about in terms of combating resistance. Now, what I'm just focusing on, as with David, is just looking at alternative treatment options. So the first thing I just want to talk about now is GRAND. So this is the Gonorrhea Resistance Assessment via Nucleic Acid Detection Project. We've been running this in Australia now for about 6 years. And as part of this, we initially just started to try and characterize gonorrhea. So we're taking isolates throughout the country and trying to work out what's novel about these genotypes, teasing out all the resistance mechanisms and trying to pinpoint interesting mechanisms of resistance. The second phase of this, which is more relevant here, is taking all that data. We've then actually developed a whole range of PCR methods to directly test for resistance directly in clinical samples. So there's two parts to this. We're trying to enhance surveillance, so just improve what we're doing with our culture, but then also trying to individualize treatment as well. Now, just to give you a snapshot of surveillance, now I'm quite proud to say that Australia is the first country in the world to actually start undertaking routine molecular surveillance for gonorrhea resistance. And this actually relates to, surprisingly, it's nothing to do with ceftriaxone or azithromycin. It's actually for penicillinase producing Neisseria gonorrhea strains. And in short, what we've done is, this is a gonorrhea plasmid that harbors a penicillinase gene. In short, we found a region, a sequence just here, that we can actually target with our PCR and give sensitive and specific detection of these strains in samples. Now, why do we want to do this? Well, it just so happens that in remote settings in Australia, particularly if you're looking at Western Australia and the Northern Territory, they're still using amoxicillin plus azithromycin as a first-line therapy. They're really keen to actually maintain that therapy, and so the only way they can do that is by having optimal surveillance to telling them, that indeed it's appropriate to use those treatments in those locations. So what they do here, and they're using these assays now to inform treatment guidelines. They still try to culture as many bugs as they can and get phenotypic testing, but for the many thousands of NAT positive samples, they just push them through this PPNG PCR and they get much more definitive levels of penicillin resistance. So just in terms of surveillance, this shows basically a model of how we can actually use just a single assay to enhance what the culture-based testing is telling us. Now, unfortunately, not all forms of gonorrhea resistance are as simple as that. I was talking about the PEN-A genes and everything before, lots of different mutations you can actually have. Now, the thing is, most other resistance in gonorrhea is chromosomally acquired, and I hope you don't mind, I've completely dumbed this down. I thought it'd be okay for dinner. But in short, so let's just pretend these little red mutations are in all these different genes. Now, the way these work is that for chromosomal resistance, these are like little building blocks. All these mutations come together, which combined confer resistance. Now, in terms of chromosomal resistance and trying to develop a PCR to test for these, this gets really problematic because a lot of these markers may be spread throughout susceptible strains. And so it's difficult often to tease out single individual markers that are going to be of use. Surprisingly though, we can get lucky, at least for a couple of forms of resistance amongst gonorrhea, in that we find these mutations that for whatever reason seem to be absolutely pivotal to the resistance phenotype. And really, ciprofloxacin just is an amazing example of this. So in terms of cipro resistance in gonorrhea, there's lots of alterations in gyrase and PAS-C that basically combined confer the phenotype. But for whatever reason, alterations at the gyrase 91 locus appear absolutely necessary to this. And to be honest, I have no idea why. David, you might be able to shed some light on this, but for whatever reason, I'll show some data on this. So this is actually looking at the gyrase 91 locus in Australian isolates. And we didn't muck around here. This was done as part of the GRAND studies. We took just over 3,000 isolates from every part of Australia, and we looked at whether or not this gyrase 91 locus was wild type or had a particular mutation, which is the S91F. Now, in short, what we found was that if it was wild type at this particular locus, this it was actually 99% sensitive and 99% specific in showing, highlighting that it's actually a susceptible organism. And just as surprisingly, so looking at the other side of the coin, if we looked at this S91F mutation, it was just as sensitive and specific in identifying its resistance. So, and notice that I'm talking about trying to predict susceptibility or predict resistance. In terms of informing treatment, it's really important that we can actually pinpoint susceptibility. So ruling the drugs in and being confident and be able to use those. So, and that was some Australian data. I really want to point out Jeffrey Klausner has done some really nice work in this area. He's recently completed a meta-analysis looking at a whole range of different studies, looking at these particular gyrase A mutations and finding very similar data on basically most data sets that are out there. Now, how can we actually use this gyre marker then? Well, we can actually certainly use it for surveillance. It's certainly an ideal tool for that if we want to look specifically at Cipro resistance or susceptibility. But using this particular marker, we can go beyond that and start to individualize therapy. So this is basically where we, as David explained, we actually have this PCR test. So if we actually have a sample goes to the laboratory, it's confirmed as gonorrhea positive, we can then actually push that through this Cipro PCR and release that result as gonorrhea positive, Cipro sensitive. And so that can actually inform treatment. Now, why do we want to do this specifically for Cipro? Well, again, it's we know, as David explains, Cipro is actually a highly useful treatment for gonorrhea, particularly if you know the strains are sensitive. That's always handy to know. But the other thing is you can actually have confident treatment decision making around this particular GRA91 marker. It is actually, as I've showed, extremely reliable. And the other thing, of course, is that in many parts of the world, there's still large proportions of gonorrhea that remain susceptible to Cipro. And a good example, for instance, Australia, 70% of cases. The 2014 data from Europe was 50%. I'm not sure if anyone can update that. I think it's still similar. So there's basically a market for it as well. Now, in terms of actually moving all this forward and actually doing some studies around this, again, I'm going to point out Jeffrey Klausner's work. I was very jealous of this study when I first saw it pop up in CID last year. But in short, what he's done was he was using an in-house PCR to basically directly inform patient treatment. And through the studies that he's done here in the US, what he basically showed was that one, treatment outcomes correlate really nicely with this GRA91 marker, but just as importantly, he did actually show that clinicians would actually use this test as well. So he showed a drop in ceftriaxone use associated with increased use of Cipro. We're basically doing a similar study now in Australia. I think the key difference though is that we've partnered with SpeeDx as part of this study to actually have a commercial test that we're using in these trials. And as I'm sure SpeeDx will want to tell you, they're just releasing that kit just now. So Liddy Tan's actually giving a talk on this tomorrow, so I've deliberately refrained from giving, presenting much information on the Cipro test from SpeeDx. But in short, this is showing at least some of the data, comparing the SpeeDx assay to culture for 163 isolates from our grand studies. And again, we're showing greater than 99% correlation of genotype and phenotype, so it's looking pretty nice. So pretty much that's it. So individualized treatment of gonorrhea, it's certainly very feasible. This GRA91 locus is just, for whatever reason, it's an extremely useful marker. And so you can confidently make decision making on the basis of this particular marker and test. And of course, the potential benefits here, antibiotic stewardship, sparing use of ceftriaxone, but also again, expanding oral treatment options for gonorrhea, which are much more, handy to use in particular settings. So that's it from me. And I just want to highlight all the grand study investigators as well, which there's quite a lot of them now. So thank you very much.